Welcome, everyone. My name is Aditya Lati. I'm one of the Grand Round directors, along with Drs. Alex Harris and Rebecca Muley. Today is our first Grand Rounds in a few weeks, and we're so happy to welcome everyone back, whether you're in person or on Zoom. Before I turn to Dr. Lisa Dixon to introduce today's speakers, just a few notes. As you may know, we've had financial restrictions on speaker travel and honoraria. We've had the opportunity to present some virtually, and some of our external speakers have preferred to reschedule till they can come in person. All of this means our schedule might be a little bit more in flux the next few weeks. Some speakers may switch from in-person to Zoom, others may wish to reschedule to another time when they can come in person, and we might have other late in the day substitutions. However, we're committed to having Grand Rounds regularly, and we wanted to remind everyone to watch for our announcements via emails for updates and to check our calendar regularly in case there are any changes. That said, we recently learned that funding for endowed Grand Rounds is permitted and flexible, and we're proceeding as usual with our endowed lectures. Also, please note we are committed to continuing and keeping our Grand Rounds buoyant, representing all of our community and bringing our department together weekly to celebrate the missions we share. To that end, our speaker today is one of our own, who you'll hear about. And next week as well, we're very pleased to bring you the next in our early stage investigator series. 3 of our junior faculty, Morgan Firestein, Mariah DeCiceri, and Jennifer Moots. This will be in person as well, and we really hope you could come and have a nice sense of community with our internal speakers. Just one note for those who are virtual, please use the Q&A feature to submit questions by Zoom. Dr. Harris will be moderating these questions. Now, to not take up any more of your time, I'd like to introduce Dr. Lisa Dixon, the Edna Edison Professor of Psychiatry, who will introduce the Susan Essock Lectureship and our today's speakers. Thank you, Dr. Dixon.
Hey. Hi, everybody. Can you hear me okay? Great. Okay. So it's my privilege to introduce the Essock lecture and the Essock lecturer. I just want to say a few words about Susan, who is here. She wants to become invisible. Susan endowed this lecture, and if I could have, how do I do the next? I have to actually do this, huh? Okay, oops. A lecture is so Susan, and her mantra as my division director and inspiration over the years was do the science and make it matter. Okay, and so this lecture really tries to celebrate the work of someone whose work is rigorous, is scientific, but has impact on the world today. So thank you, Susan. And you can see the list of previous awardees. It's an incredible list. Okay. So let me just take a few moments to introduce Michael. He is currently a professor of psychiatry here at Columbia and a research psychiatrist at the New York State Psychiatric Institute. After attending medical school at UVA, Dr. Compton had a journey where he did most of his earlier training at Emory, and then he spent some time at GW and Lenox Hill. He came to Columbia in 2016, and we had the good fortune for Leah Pope to come to us with Michael. So we got 2 great scientists and members of our community. Dr. Compton is a fellow of the American College of Preventive Medicine and a distinguished fellow of the American Psychiatric Association. He's also board certified in lifestyle medicine and a member of the American College of Lifestyle Medicine. He has lots and lots of papers, lots and lots of grants, and I'm not going to go into that. I'm just going to emphasize a couple of things. One is I always like to look at what are people's self-identified contributions to science. Right? We have to put that on our documents. One, a 3-component intervention to improve food and nutrition insecurity among individuals with SMI at mental health housing agencies. 1. 2, food insecurity among individuals with SMI and the impact of food insecurity on mental health generally. And also, in general, social adversities among individuals with SMI and the impact of social determinants of health and beyond. So I think what you see is where Michael's commitment is in this real world of people who we serve who may not have enough to eat on more than one day, at a time. Finally, I want to highlight just a few of Michael's books, because Michael still writes books. They're just evocative of his breadth of knowledge and scholarship. One he just wrote with Mark Manso, Struggle and Solidarity, 7 stories of how Americans fought in their mental health for their mental health through federal legislation. Another book that is led by Leah, Entangled, How People with Serious Mental Illness Get Caught in Misdemeanor Systems. And then I have to say my favorite, to come out in 2025, Veggie Smarts, a doctor and farmer grows and savors 8 families of vegetables. Okay. And finally, another forthcoming book, Food, Nutrition, and Mental Health. We're so glad to have you here, Michael. And thank you for sharing your expertise with us.
Thank you, Dr. Dixon. And thank you, Dr. Essock. I'm really honored and privileged to be here. I'm going to cover a lot this morning, but I promise that this address will be shorter and more factual than the address we heard last night. These are my disclosures. I'm going to be talking about a few of our findings from 4 R01s, from a couple of R34s, from a National Science Foundation funded grant. I'll mention a current Pew Charitable Trust's grant. I do receive book royalties from my 11 books to date, and my book royalties add up to buy me enough of this to keep me jazzed and jacked to write my next book. So that tells you that either my books are really unsuccessful or else I drink a lot of Diet Mountain Dew. These are our learning objectives. I want you to be able to list some common misdemeanors that our patients get arrested for, to describe the CIT model in law enforcement agencies, and explain some ways that we can reduce arrest through crisis response reforms. This is the outline. I'm going to tell you how I got started in this line of research. I'm going to explain what the problem is that my research seeks to address. I'm going to talk about 4, actually, of my research pathways. I don't have time to cover the 5th. And then some of my current research interests. So how I got started here at Grady Memorial Hospital in downtown Atlanta. It's a county hospital, much like Bellevue. And I was on the 13th floor, an intern with a lot of hair, so much hair that I had a ponytail. And I was an intern, a psych intern, evaluating patients in the middle of the night, learning a lot from the nurses. And we would occasionally have prisoners brought in for an evaluation in the middle of the night. My job was to do an evaluation, start them on some Risperdal, maybe some Cogentin to complement their Haldol. It was a relatively easy job, but what was perplexing to me was their charges. They, first of all, were not prisoners. They were coming in from the Atlanta City Detention Center in pretrial detention, having not yet seen a judge, for charges like disorderly conduct, criminal trespass, loitering, obstructing the job duties of a police officer, etc. And I became really interested in what are these charges? But I went on to prepare myself for my K award, which was about first episode psychosis, about trying to understand the drivers behind the DUP, duration of untreated psychosis, why it is that our patients with early psychosis wait so long and their families before coming into treatment. We looked at 25 urban African-American first episode patients admitted to Grady, looked at their pathways to care, and we saw that these 25 patients had 83 contacts during their pathways to care, 17 of which were with the police, which I thought at the time was strange. We ended up finding that in my K ward, among 109 first episode patients, 57.8% reported a history of prior incarceration. We also found that those previously incarcerated had a longer duration of untreated psychosis and therefore a poorer course of illness. And finally, we concluded that we're going to need to look in jails to identify first episode patients. Some 37% in this sample had been incarcerated during their duration of untreated psychosis. So I was moving along with my K award. I sort of put these things aside. But ultimately, my research career landed back on this problem once again. And the problem is really criminalization. It's the overrepresentation of people with mental illnesses, especially SMI, in all facets of the criminal justice system. These are some of the drivers of that overrepresentation, criminalization. We've all heard of trans institutionalization, but it's also because crisis response in our country historically has involved the police. It's because many of our patients struggle with substance use disorders. It's because many of the crimes they're charged with are actually crimes of sustenance related to poverty, social disadvantage, et cetera. It's related to our reliance on law enforcement for transport. It's related to the fact that our patients tend to miss appointments, including appointments at court and with their probation officers. These are some of the complex problems driving criminalization. There are about 10 million arrests each year in the US. About more than 80% are for low-level offenses. I'm talking about misdemeanors this morning. Many of our patients get charged with so-called quality of life crimes or public nuisance charges. And obviously, if you're arrested and you go to jail, that interferes with your treatment and your recovery. So I'm going to walk through the first four pathways of my research over the past 20 years or so that has tried to dissect and come up with solutions to these problems. Specifically with CIT, that's a program that's embedded in law enforcement agencies. Then I'm going to talk about Opening Doors to Recovery, a program that's embedded within the mental health sector. And then finally, the linkage system, which is a partnership between the law enforcement sector and the mental health sector. But first, a little bit about exactly what our patients get arrested for. Meryl Rotter and I have written about this, and we pointed out that the overrepresentation of people of color and individuals with SMI across all levels of the criminal legal system results from really social and economic forces, the social determinants of health, as well as systemic racism. And criminal legal system involvement itself is a social determinant of mental health as well, driving course and outcomes. Our patients, when they have an interaction with police, they have a heightened vulnerability. They commonly have had prior negative experiences with police, which might impact how they interact with the officer. We know that their criminal legal system involvement amplifies their stigma, et cetera. And from the perspective of law enforcement, they view this as not part of their core job function, crisis response, responding to people with SMI, but yet they have to do it. They receive little training, they want more training. They want more tools to help them when they're interacting with someone with a mental illness. They view our system as deficient and offering inadequate follow-up. A word about the sequential intercept model. This is a commonly referred to model. It maps out the criminal legal system and points out areas where we can provide off-ramps for our patients or points of diversion to come out of the criminal justice system and back into the mental health system. Most of my research has focused on Intercept 1, and in more recent years on Intercept 0. Why? Because the initial police encounter obviously is the point of initial contact with the criminal justice system. Officers often are serving as de facto mental health workers out there in the street, having to make decisions about our patients. And usually they have very few options at hand. They can either transport to the ED if the person meets criteria or is willing to go voluntarily, or they can execute an arrest. And as I'm going to describe, an officer can execute an arrest nearly anywhere, anytime, for anything. Or else they can do nothing, which is usually not a sufficient response because others want something done with the situation. So what do our patients get arrested for? We did a study in Savannah, Georgia, involving 240 patients with serious mental illnesses coming out of an inpatient setting that I randomized into a study looking at opening doors to recovery versus intensive case management. I'm going to describe this study in just a bit. But as part of the study, enrolling in the project, we were able to get their Georgia state rap sheets, which is their record of arrests. We looked at their lifetime history of arrests in this paper, and we found that among the 240, 171 had been previously arrested. That's 71%. Among them, their average lifetime arrests was 8.6 lifetime arrests with a total of, on average, 12.6 charges. So we looked at their rap sheets to see, well, what exactly are they charged with? This is a rank list of the most common charges among these patients with serious mental illnesses, either a psychotic disorder or a mood disorder coming out of an inpatient setting. Criminal trespass, number one, a misdemeanor. Willful obstruction of law enforcement officers is number two, a misdemeanor. Disorderly conduct, shoplifting, probation violation, etc. We then took the patients who had had a total of at least 4 arrests in their lifetime, and we looked at their earliest 2 charges, roughly at the ages of 20 to 21, and their most recent 2 charges, roughly at the ages of 30 to 35, 33 to 35. And we see that the rank list, if you will, differs from the earlier charges to the most recent charges. Marijuana possession becomes way less common. Disorderly conduct becomes much more common. And we start to see charges like willful obstruction of a law enforcement officer, either a misdemeanor or a felony. We see probation violation becomes the most common charge in this sample. Failure to appear to court, a brand new charge because you missed an appointment, is the 5th most common charge among patients at this point in their illness. So what do our patients get arrested for? Mostly minor misdemeanors in which the arresting officer has a lot of discretion, as well as violations of the legal process. We also looked at data from New York State, again, trying to figure out what are the most common misdemeanor charges that we need to focus on. We looked at all arrests in New York State from 2010 to 2013, and we were able to dichotomize those arrests into those most likely occurring among someone with an SMI based on Medicaid billing data versus arrests occurring among people most likely not to have SMI. These are the UCR codes among those without the SMI indicator and with the SMI indicator. You see that petty larceny or theft is more common. Driving under the influence is way less common. We see that fraud is more common. Aggravated assault is more common, but simple assault is less common. So we begin to see the profile of the types of misdemeanors that our patients are most likely to be charged with. Criminal mischief is more common, whereas having dangerous weapons, for example, is less common. This is the rank list, once again, for those without the SMI indicator and with the SMI indicator. We see that DUI-related charges are common in the general population, but not among our patients. The same for weapons charges, but criminal trespass creeps onto the rank list among people with serious mental illnesses. So these are the charges that we really wanted to focus on in a National Science Foundation funded project, where we went to 4 cities and really tried to understand in 4 different cities, how are these charges used and processed, these misdemeanor charges among people with serious mental illnesses. I'm not going to walk through these maps, but these are tiny snapshots of the much larger system maps of the criminal justice system, specifically misdemeanors, in 2 of our 4 cities. We looked at Atlanta, New York City, Philadelphia, and Chicago. And it simply shows that these are complex systems, these misdemeanor systems where our patients are moving through with some opportunities for diversion. We ended up writing 2 or 3 or 4 papers, and then we decided we've got so much data that we need to just put it into a book. So we wrote a book, as Lisa mentioned. It's called Entangled, published just a few weeks ago by the APA. And it's interesting because it drills down on some of these specific charges, like criminal trespass, like shoplifting, and like obstruction. And I'm going to spend just a few minutes doing a little bit of a dive into these three specific misdemeanors. So criminal trespass, we all sort of know what that means. It's a legal tool for managing people's behaviors in spaces. Its use has declined in recent years in some cities, like in Philadelphia. We found that criminal trespass is sort of being decriminalized, if you will, because of some lawsuits. That the statute was being used too broadly and in a discriminatory way. But still, many jurisdictions use it as a critical tool to meet the needs, especially of business owners who want to move people along and off their space, off their property. In many states, there are caveats in the law that can escalate it to a felony offense. By the way, a misdemeanor is usually sentenced at up to a year in a county jail. A felony is usually sentenced at more than a year in a state prison, just for those differences. This charge really stems from a long and sordid history that really stems from the institution of slavery. But the charge eventually traveled north. In the civil rights era, this is a charge that played a prominent role in the lunch counter sit-in cases, and then faced some legal scrutiny at the time for being too broad and allowing officers too much discretion. In many jurisdictions across the country, you can go to a bank branch, you can go to a gas station, you can go to a small shop and see a sign like this. It basically says that if the store owner is not here, if the bank manager is not here, we're going to allow the local police department to be the person in charge and to therefore have the authority to execute an arrest for criminal trespass, even if the property owner isn't there. So it's a way of net widening so that this charge is more accessible to police officers. Shoplifting, a very, very different type of charge. There's been a lot written about shoplifting. This is the most common misdemeanor in the US. Lots of people shoplift. It is associated with what the retailers call retail shrink. In other words, they lose a lot of merchandise through shoplifting, although some of it's also because of organized retail theft, employee theft, inventory control failures, etc. Every state has this charge. They're all slightly different across the states. The states have different caveats for how much the shoplifting amount needs to be in order to escalate from a misdemeanor to a felony. Some states tie it to a trespass notice. Like I mentioned, there's a rich history examining this charge. It's also been linked to antisocial personality disorders, substance use disorders, impulse control disorders. It's more common in non-Hispanic whites, but we know nonetheless there's consumer racial profiling. Now here, the officer has a little less discretion because the shop owner, the store owner, has a say in what happens in the scenario as well. In Georgia, for example, and many other states, if our patient with a serious mental illness gets arrested for shoplifting 10 years ago for a bag of chips, 5 years ago for a pair of socks, last year for a can of Diet Mountain Dew, and this year for a tube of toothpaste, they're going to prison for a felony. 3 strikes and you're out, 1 to 10 years in prison. Willful obstruction, a very different charge, but again, among the most common charges. By show of hand, how many people get frustrated from time to time with your patients or your clients? Surely, all of us, we get frustrated. They obstruct our work. There's only one profession, however, where all of these frustrations and rudeness and refusal and obstruction can be charged as a misdemeanor or even a felony. And that's when you obstruct the work of a law enforcement officer. It's called obstruction. A number of other misdemeanors are related to this charge, like menacing, disorderly conduct. It's also sort of been called colloquially contempt of cop, with the implication that this can be a legally dubious charge or an emotional reaction of an officer who's feeling challenged or slighted. There's been a lot written about this charge of obstruction because the idea is that officers need some of these charges that allow them broad discretion so that they can do their work, like keeping the sidewalks passable, the roadways drivable, de-escalating situations, and simmering crowds, et cetera. So, the legal profession views this as a needed charge, a needed legal tool, but our patients tend to get entangled in it, especially because some features of SMI itself can appear to be uncooperative behavior, right? Which this charge is really about uncooperative behavior. So it's a very common charge among our patients with SMI. So those are some of the most common charges. Now I want to talk about three programs that are designed to reduce the risk of arrest among our patients. The first is CIT. This is a program that's embedded in law enforcement agencies. What is CIT? In 1988, there was a fatal shooting of an African-American man with a mental illness in Memphis. There was a public outcry. The Memphis Police Department joined with NAMI and joined with the University of Memphis and created CIT. That's the team. That's the team in CIT. NAMI, local police, and local mental health services. CIT has 10 core elements, like having a 24/7 easily accessible drop-off site for officers to bring people. The goals of CIT are to improve verbal de-escalation skills, to encourage officers to transport people with mental illnesses to the ED and to not arrest them. So it's a form of pre-arrest jail diversion. One of the features of CIT, the central feature, I guess, is a 40-hour training program for self-selected police officers who then become first responders for behavioral health calls. There are probably since 1988, about 5,000 law enforcement agencies across the country who have implemented CIT out of about 18,000 law enforcement agencies. In New York State, we have many CIT programs. OMH and the legislature each year expands so that we can bring CIT into additional jurisdictions. There's an organization around CIT called CIT International. There's an annual conference, etc. That's CIT. When I was back doing my K Award, Georgia decided they wanted to implement CIT. I was at Emory University at the time. So a delegation of us went to Memphis to study the Memphis model of CIT to bring it back to Georgia. I was able to write a book specifically for police officers conveying the principles of CIT, and Mrs. Carter wrote the foreword to that book. This is a typical CIT training week, a 40-hour week with usually about 20 officers in the class learning about psychosis, about mood disorders, dementia, substance use disorders, practicing verbal de-escalation skills. This is a typical CIT training week. They go out and visit sites so that they can interact with someone in recovery, with family members. Again, a lot of verbal de-escalation skills training. So I was working on my K Award so many years ago and decided, well, let me do some research on CIT as well. We did a number of unfunded research projects, small surveys. This one in 2006 in psych services, 159 police officers at the Atlanta Police Department. We surveyed them after CIT training. We wrote about the evolution of the Georgia CIT program. We studied self-efficacy, social distance stigma. We did focus groups. We looked at knowledge retention. We looked at beliefs about the causes of schizophrenia before and after CIT training, the characteristics of the patients that CIT officers bring to the ER. We even had a paper published in Schizophrenia Bulletin. I had been trying for years to get a paper published in Schizophrenia Bulletin. The first paper published on police officers in the Bulletin, so I'm proud of that one. We surveyed police chiefs and sheriffs. So a lot of research projects that ultimately brought me to an R01 on CIT. This was the first R01 that NIMH funded to study police officers. Amy Watson, my colleague, then got the second, and the two of us now have the third, which I'm going to tell you about. This R01, we worked at 6 police jurisdictions in Georgia. We brought in 586 police officers, sat them down, and had them complete about a 3-hour paper and pencil survey. We measured everything that you can imagine in terms of attitudes, knowledge, self-efficacy for working with people with psychosis and suicidality, stigma, their de-escalation decisions, their referral decisions. Of those 586, 251 had previously received CIT training at a median of 22 months ago. A couple of years ago, they received their CIT training. And we found that for nearly every variable, the CIT officers did better in terms of knowledge, attitudes, skills, stigma, etc. We also looked at some of their actual encounters, more than 1,000 encounters among this sample, and we found that CIT officers were less likely to make an arrest. We did path analysis to study how knowledge ultimately leads to better referral decisions. We looked at the theory of planned behavior and how that might explain how CIT training works. We were able to look at the influences of neighborhood characteristics on their encounters. We looked at a subsample of people with intellectual and developmental disabilities. And this paper ended up being important because perhaps the biggest controversy in the world of CIT is, should we just train all officers in CIT, or should we only train self-selected officers who are volunteering, which is one of the core elements of the Memphis model? As it turns out, among our 251 CIT officers in this study, we happened to ask them in the demographics sheet, did you volunteer for CIT training? Or did someone tell you you have to go to CIT training? Were you volunteering or voluntold? And as it turns out, the volunteering officers do better than the CIT trained officers who were voluntold. And so this is the only evidence that we have to support the core element that responding CIT officers should be volunteering officers. My dear colleague, Amy Watson, who's at Wayne State University, and I have been studying CIT for all of these years. We now say that CIT can be designated as an evidence-based practice for officer-level cognitive and attitudinal outcomes. But we need more research on other types of outcomes. So now she and I have an R01, the third R01 that NIMH has funded on police officers to do a randomized controlled trial of CIT training for police officers. We're working at 7 sites across the country. Each site gives us about 20 to 45 officers. We assess them at baseline. So let me tell you how this works. Let's take Phoenix as an example. We fly into Phoenix. We've already recruited about 40 officers to participate in the study. 7 of us fly there. We spend the whole day assessing the officers, paper and pencil surveys, but also their actual skills and behaviors. And then at the end of the day, we randomize those officers. Half of them end up in a CIT training week in their police department a week and a half later. And the other half of the officers don't go through CIT training for 6 months. We assess them in terms of how they interact for 5 minutes with someone with psychosis with agitation while we're video recording them, with someone with depression and suicidality, 5-minute video, with someone with mania and refusal to leave a private space. How do we do this? We travel with 3 professional actors who are really, really good at portraying these 3 psychiatric disorders. They're basically serving as standardized patients. And at the end of the study, we will have more than 2,000 videos that will be blindly rated on a whole host of verbal de-escalation skills type metrics, blinded to the study site, blinded to the treatment arm, blinded to the time point. We've published on the protocol. I put this up to show all of my colleagues. Hanga is our statistician. Liz Jackson, who's in the room, is our ex-Marine research assistant. Infu, who's in the room, is our research coordinator. They run this project, and it's a really, really interesting and fun project. As we collect data, we're writing some methods papers on how we went about developing these scenarios. We're writing a paper now on how to work with professional actors in the context of policing research. Now let me switch to a program that's embedded not within the criminal legal system, not within police departments, but within the mental health system. This work I did in Savannah, Georgia, and it's about opening doors to recovery, ODR. So what is ODR? About 15 years ago, NAMI, Georgia, pulled together a number of partners at the Carter Center in Atlanta, and they literally declared war on the mental health system in Georgia. That's how dissatisfied they were with outpatient, community-based care for people with serious mental illnesses. And they decided, let's just create a brand new form of community support that's recovery-oriented for people with SMI. Opening Doors to Recovery is what they called it. It includes 3 navigators, a professional navigator who's a licensed social worker, a peer navigator who's a peer specialist, and a family navigator who's a family member of someone with SMI who now has a full-time job on the ODR team. The 3 navigators work together. They have 2 goals. One is to keep their clients out of the deep end. Out of the deep end. What is the deep end, NAMI? NAMI, Georgia says the deep end is hospitalization, homelessness, and jail. So from the beginning, the model is based in part on helping people stay out of jail. The 3 navigators focus constantly on 4 tenets. ensuring that their patients have adequate treatment, that they can find safe and stable housing, that they can create a meaningful day, and that they can use technology for their recovery. The navigators also map out local services and gaps in services, and they have multiple connections in the community. So we did an initial project of ODR in the Savannah area with 100 patients, and we had positive results. So we went to the NIMH and got an R01. We also have written about this family navigator role because it's sort of a novel addition to the treatment team, as well as this concept of a meaningful day, which we really believe is critical to helping people stay out of the deep end. We were able to get the R01. We did a randomized controlled trial. This is the 240 patients that I mentioned earlier that we were able to get access to their rap sheets. They were randomized into ODR versus intensive case management as defined by Georgia. At the end of the study, we were able to pull their rap sheets once again and look at their charges over the past 12 months. Those randomized to ODR, 20.5% had been arrested in 12 months. Those randomized to traditional intensive case management, 39.8% had been arrested over 12 months. So this is a pretty drastic difference in the rate of arrest between the two groups, with ODR clearly looking good. I'm not going to talk about hospitalization and recovery metrics right now. But in the opening doors to recovery group, there were a total of 39 arrests over 12 months. In the case management group, 108 arrests over 12 months, which when you sum up the total societal costs of all those arrests, it sums to about $3,000 per client in the ODR group and about $6,000 per client in the control group. So we can develop programs in the mental health system that reduce the risk for arrest. We don't have to do all of this work in the criminal justice system. The third sort of research pathway that I'll briefly talk about is a collaboration between the mental health system and the criminal justice system. It's called the linkage system. And let me sort of explain how this works. Who has ever been pulled over by a cop? And what does that cop do? He takes your license and he goes back to his car. And he sits in his car for like 5 minutes while you're sweating bullets. You're afraid you're going to get a ticket. You're hoping that you just get a warning. I'm always like, I do police research. So do you know what CIT is? What is he doing in his car for those 5 minutes? He's entering your identifiers, your date of birth, your license number, first name, last name, height, eye color, hair color, into his in-car laptop, so that then several databases held by the state can be queried to see if there's a match between your identifiers that the cop entered and the database held by the state. Like, every state has a database with all of the people who are wanted. They have a bench warrant for their arrest. If your identifiers queried to that database create a good enough match, the officer is told this person has a warrant out for their arrest. Another database is, are you under protective orders? Another database is, are you on probation? Another database that some states might query is, are you a sex offender? Maybe, who knows? Another database is, are you older than 150 and you're still pulling down Social Security? Like, so the state operates these databases, right? And so what we did with the linkage system is we worked with the Georgia Bureau of Investigation to create a new database that we could enter patients into with their consent, of course, so that when an officer runs a query, in addition to all of those other databases being queried, our database would. And if there's a match, the officer gets an electronic notice that says this person has mental health considerations. Please call this number. That's all it says. He can call the number, and it goes to a social worker who works in the mental health agency where the patient is in treatment. And rather than that social worker saying, I can neither confirm nor deny that this person is in treatment here, they're able to have a brief conversation. And the hope is that once in a while, when an officer was thinking about making an arrest for criminal trespass, disorderly conduct, willful obstruction, that maybe that short conversation with the social worker might actually prevent an arrest. That's how the linkage system works. It's actually part of opening doors to recovery. It's one of the many ingredients of opening doors to recovery, in addition to the 3 navigators and the focus on meaningful day and those sorts of things. But I thought, wow, this is a really interesting ingredient of opening doors to recovery. So let me study it in isolation. So we got an R34 to really develop this intervention, to study it among 200 patients. We did a lot of acceptability interviews. The cops like the idea of this. Patients like the idea of it because they know that when they interact with officers, sometimes they're at their worst, and they would like the officer to know that they're in mental health treatment. Maybe they're off their medications, and maybe they can get an appointment tomorrow. We did an initial feasibility study with 200 patients who were in the database for 12 months. And over the course of those 12 months, our linkage specialist, the social worker at the mental health agency, received 31 calls. And we're pretty sure that among at least 3 of them, an arrest was averted. It's a very small effect size. In the year before enrollment, 38.7 had been arrested. 38.7% had been arrested in the year before their enrollment, according to their Georgia rap sheets. 30.7% in the year being in the database. It's a small difference. I don't know if it's meaningful, but it gave us an effect size that Hanga could then use to power up a randomized controlled trial, which is what we've been doing over the past few years. We enrolled 1,400 outpatients with serious mental illnesses in the Savannah area and the Atlanta area. And this study got tangled up. It got entangled in the research suspension. And so as we had 264 patients still remaining in the study, they had to be abruptly pulled from the study because of the suspension. We don't yet have access to the 1,400 rap sheets, but the GBI is ready to give them to us. And then, Hanga, we're going to have to work on figuring out how to do this analysis given the glitch. We'll see. I was going to talk here about a third sort of research pathway about Rikers Island. And this part was important to me in this talk because it sort of brings me full circle back to the days when I had my K Award and I was doing first episode psychosis research. And I wrote that paper about how we need to get into jails to find first episode patients because they tend to be there. 37% of first episode patients in my K Award, as you might recall, were detained in jail during their DUP. I was at Lenox Hill Hospital. I had the privilege to meet Leah. She and I wrote a couple of grants. We did a big project at Rikers, and I don't have time to talk about it. So we need to bring Leah up for Grand Rounds to talk about that project at Rikers. So the 3 of us, we are doing a lot more now. By the way, I'm the one without the hair here. We're doing a lot more nowadays at Intercept Zero. Yes, we still study police encounters and CIT, But we're really emphasizing that we need to shift resources and responsibility for responding to non-criminal social and behavioral health vulnerabilities to the health and social services sector. We're studying more and more about 988, about mobile crisis teams. We have a Pew Charitable Trusts grant right now where we're doing a full-on policy analysis of all 50 states and how the 50 states have leveraged both CMS Medicaid and SAMHSA dollars over the past 10 years to try to bolster and improve their crisis response services. It's a really interesting project. Our policy analyst is in the audience, Rashi. She's spending her days over the past several months digging into Medicaid SPAs, state plan amendments. Amy, Leah, and I are also really interested in workforce-related issues around crisis response. We believe that there needs to be a whole new discipline that's sort of related to EMTs, but for mental health. We call this discipline community behavioral health crisis responders. We're writing about it. We're working with NAMI National, who funds this work. The idea is there aren't enough social workers to go around to fill every mobile crisis team and every community-based mobile crisis response. And so we need a new discipline. And we're defining what their core values should look like, what their skills and competencies should be, and even what their training and ultimately their credentialing needs to look like. We're also working with the Sozosei Foundation to create and enact a strategic research agenda for decriminalizing mental illness. And I think I'm going to wrap up here, but I just want to mention a few of these other intercepts that I haven't talked about this morning, especially in the court system and in community supervision, which is probation and parole. And I just want all of us who have patients with serious mental illnesses to really know when our patients have a court appointment. Because as we know, failure to appear to your mental health clinic appointment, did not keep appointment, is very, very common. And so our patients tend to miss their court appointments as well. When that happens, though, a bench warrant is issued. The judge says this person is now wanted. There's a bench warrant. And so the next time our patient has an encounter with a police officer and that police officer takes the state ID, runs the background check, he's going to identify that this person has a bench warrant and then go ahead and arrest them. And our patient is not going to even know what's going on at that point. So know whether or not your patients have court appointments. Similarly, if your patient is on probation, know what those appointments are and need to look like and what the stipulations are, because as I pointed out at the very beginning, probation violation is probably the most common charge among our patients. And so I just want to thank Dr. Essock, thank Lisa, thank the division for having me and allowing me to speak on this topic. And I'm more than happy to hear your thoughts about anything that I've said. Thank you.